Good afternoon, everyone. Thank you for this opportunity to present the paper in this prestigious conference. I am Dr. Jeevan Kishore from Jimmers Medical College and Hospital, Baroda. My paper is about a reserve ring fixator for management of Shanska type 5 and type 6 proximal tibia fractures. Proximal tibia fracture, when you get a case in the emergency, what comes in your mind? We start to think. The pictures start striking in the mind and we start to think about when to operate, follow scan method, wait and watch, to conserve or to operate, plate it or do an external fixator, and what else can be done. These fractures are always challenging with the complication rates such as infection, joint stiffness, prolonged knot weight bearing, malunion, arthritis, and vascular injuries and its complications. Complex tibia fractures or high velocity injuries mostly, maybe open injuries, and may be associated with soft tissue injuries like the collaterals and the cruciates. In our study, Shanska type 5 and type 6 proximal tibia was taken, and adult age group patients were included, and open injuries up to grade 2, and patients without systemic injuries and neurovascular injuries. Out of 30 cases, we had 21 cases of type 5 and 9 cases of type 6, and we had around 6 open injuries. Out of 30 patients, majority were middle-aged men with high velocity injuries, and the mean duration of hospital admission to operation was 5 days, around 5 days, and they had to stay for around a week. In the post-operative period, radiographs were recorded and knee RM was started after 24 hours in type 5, and weight bearing in type 6 after 48 hours up to pain tolerated. And we followed up all patients after every month, and final follow-up at 6 months, and every patient was taught the pin track protocol, and frame was removed after clinical and radiological union. Final outcome assessment was done by Colstrom all-around scoring system, and results, there were excellent and good results about 75% of the cases, and we had poor results in 10% of the patients. And this is the case one, a 44-year-old female, and she was diabetes. She had a comorbidity of diabetes, and she was irregular on treatment. And it was a type 5 fracture. This was the post-op, and X-rays at 2 months and 3 months. And this is the union after the frame removal. This is the case 2. This is a type 6 fracture. So the 3D CT done for the intraarticular, and this was the intra-op images, and this was the post-op images. And case 3, type 6 fracture with impending compartment. Across knee fixation was done. And case 4, this was type 6 again, and this was the local condition on presentation. This was the intra-op and post-op images, and 3 months post-op. There was another case of 45-year-old male. He had intra-articular comminution also, and there was a mini open incision, and intra-articular reduction was achieved. And this was the post-op. And this post-op knee RM of the same, and this is the post-op at 3 months showing union also. This is another type 5. This is the intra-op knee flexion which we could achieve by fiber rings, and this is the union x-rays. Usually conservative management in type 5 and type 6 fractures has given poor results, and pin tract infections, loosening, and loss of reduction during the course of treatment has been a major problem with the traditional monoplanar external fixator. And advantages of Elizaro over open redirectional plating is minimal soft tissue injury. Periosteum is always intact, which helps in osteoinduction. Early range of movement and weight bearing stimulates healing, and always we had a scope of realignment and minor adjustments during the course of the treatment. And limitations were always it's not possible to achieve intra-articular reduction anatomical, and concomitant cruciate ligament injuries could cause early OA or late knee instability, and there is always a risk of losing the terminal flexion and extension. So the take-home message is Elizaro external fixator can be used for as a definitive fixation also on the same sitting, and common complications like skin necrosis, infection, and extensive soft tissue stripping and hardware complications could be avoided with Elizaro. And early skeletal stabilization and aggressive post-op physiotherapy is the key to achieve functionally range of movements, and we can achieve intra-articular reduction also by a mini open session. Thank you for patient listening.
Though it is a free paper.
To all of you, I'm Dr. Srinivas. I'm very sorry for the delay, and I thank organizers for giving me opportunity for the presentation. My topic is Y-frame of chest fixator for management of proximal humerus fractures in elderly. It is relatively simple frame and it can be applied even by the beginners. So proximal humerus fractures, they constitute around 5% of total skeletal fractures. They are frequently seen in elderly patients following trivial trauma due to osteoporosis. In osteoporotic patients, the conservative line of management is tried, but in a displaced fracture, the operative treatment is favored. The conservative management has its own problems, that is disadvantage of being a dissembling shoulder stiffness. So various treatment modalities are available and they are all time tested, but the surgical treatment which needs extensive soft tissue stripping adds to the morbidity, and also there is a possibility of infection. To minimize this problem, external fixators which can be applied with a lesser time and less invasive conditions, they are favored. Dr. B.B. Zoshi, who invented this JESS system, that is Zoshi's external stabilization system, it is a very minimally invasive technique, works on the principles of ligamentotaxis. It has basic inventory in the form of link joints, rods, distractors, connecting rods, and it's very cost effective as well. So in the surgical procedure, I will brief you. Around 2 to 2.5 mm threaded, preferably threaded wires are used in an osteoporotic bone, which are passed into the proximal humerus in 3 directions. We are sparing the axillary nerve and the axillary artery. There are 3 directional wires, gives a better stability to the fixation, and you can add on like this more wires to as per the fracture geometry. After passing these wires are connected with a 3 mm C-shaped rod, connecting rod, with the help of these link joints. So this completes the metaphyseal construct. Then 2 to 3 wires of 2 to 2.5 mm are passed distal to the fracture site in a perpendicular to the long axis of the bone, sparing the radial nerve, and they can be passed in an angulated manner so that it adds to the stability. Once these wires are fixed, they are connected with the help of rods. They are shaped in a form of, they are slightly bent. So after connecting this diaphyseal and a metaphyseal component, this assembly looks like a Y. Therefore, it is called as a Y-frame. And this is how a Y-frame looks like, courtesy to the textbook of JESS. And now coming to the case series, we operated around 8 cases of age between 60 to 75 from year 2020 to 24. The average fracture union time in all the cases was around 10 weeks. and 6 patients could complete their 1-year follow-up. So post-operative protocol, immediate shoulder mobilization was initiated as per the pain tolerance. Average antibiotics for IV antibiotics were given for 3 days and 7 days oral antibiotics. Average hospital stay was 5 days, and after initial 3 weeks of pendulum exercises, overhead shoulder abduction was initiated. All the patients were followed up for 136 months and 1-year interval. Post-operatively, the pin tract infection, loosening of the fixator, and X-rays were done to assess the progress of union. So this is a case of 60-year-old active male with a IHD and diabetes mellitus. He was on blood thinners, sustained his displaced fracture, and conservative line of management was advised to him, but he opted for surgical intervention. So we fixed this fracture with a Y frame. These are post-operative pictures. After 4 days of fixator application, we initiated the pendulum exercises. These are the pendulum exercises the patient is doing on the 4th post-operative day. And this is the range of motion at 10 weeks, just before the fixator removal, which is pretty reasonable, and fracture is united. This is another case of 75-year-old lady with a severe COPD. She was denied surgery from other hospitals. She came to our hospital, was subjected for plating. The option of hemiarthroplasty was not there, but once the deltopectoral approach was taken by another surgical team, they found that the bone is extremely comminuted and osteoporotic. The fixation was extremely difficult. So later on it was shifted to external fixator, that is Y frame. So we applied this Y frame to the patient. You can still see the suture line and for the deltopectoral approach. This is at 10 weeks. You can see the healthy suture line and a Y frame in situ. Here, due to the excessive osteoporosis, we added one more rod to the frame. Since the condition of the fracture, age of the fracture, and osteoporosis was pretty bad, so we were not hopeful about much of a range of motion in this case. So, but we could achieve a pretty fair outcome in this case. So, before the fixator removal, we just assessed the mobility of the fracture under C-arm. And this is the fixator removal, and this is a relatively fair outcome. I will not say very good outcome, but the patient is able to use her hand. Now I'm sorry for this case that I don't have a pre-operative X-ray. This is a 65-year-old male who is IHD case with a left ventricular function of 30%, had a comminuted proximal humerus fracture. It was treated with a just fixator Y frame. And this is a minimally invasive fixation, you can see. And this is a range of motion of a patient at the time of fixator removal. And after 8 months of follow-up, you can see the union, and he has become almost like a Mike Tyson. So there are different methods of fixation of proximal humerus fracture, from conservative to the operative. Every method has its own limitations and complications. Osteoporosis makes the rigid fixation very difficult. The cortical bone in osteoporosis constitutes only a thin shell. Therefore, external fixator offers a better option in these type of fractures. Postoperative adhesions also limits the further range of motion. Therefore, that is another problem, especially in elderly. Excessive soft tissue increases the risk of infection. Amongst the internal fixation, the Philos plate has a reasonable outcome, but in a JES, which is a minimally invasive, it provides a pretty stable fixation in an osteoporotic bone, and since it works on the ligamentotaxis, it gives a better result. The smaller K-wire used here have a less chance of neurovascular injury. So there are certain complications also of this method, that is K-wire loosening, pin tract infection, possibility of malunion, and of course, like other fixation methods, you can't permit a full weight lifting in an earlier days. But there are advantages, more advantages as compared to a disadvantage, that it is minimally invasive, simple construct, easy application, stable, biomechanically stable construct, it has a short hospital stay, promotes early rehab, lightweight, easy to remove, and cost effectiveness. So, the wide frame of a chest fixator can be considered as an alternative for the option for the definitive treatment of the proximal humerus fractures in osteoporotic elderly patients. Thank you so much. Thank you.
Thank you for finishing in time.
Thank you so much.
So I am Dr. Edinburgh from Tamil Nadu. I am going to present my paper on definitive fixation using Elizoro fixator on open tibial fractures and analysis of functional outcome. So India ranks number 2 in number of road accidents, and the state which I come from, Tamil Nadu, stands tall. It comes first in the road traffic accidents as per the 2021 statistics. So we get more and more number of open tibial fractures, especially complex open tibial fractures. And traditionally these fractures are treated by a temporary AO in external fixation, management of wounds followed by internal fixation. But these are not without complications. There is a high chance of deep infection, delayed union and bone grafting, need for bone grafting as given classically in this paper. And also there will be pin site infection which will preclude the use of internal fixation later if we plan so. So we have to devise an optimum treatment protocol for addressing these injuries. And this protocol must be cost effective also, as our patients don't have insurance and the treatment is purely borne by the government. So we aim at studying the factors which affect the functional outcome of treatment of these fractures using Elizoro external fixation, and we used Tucker's criteria to assess the functional outcome. And our patients are aged more than 18 years, male and female, and presenting with the trauma department, open tibial fractures, and pediatric patients, patients with malignant bone tumors, metabolic bone diseases, and fractures which are aged more than 7 days and are excluded from this study. So we had a total of 28 patients, 3 patients last follow-up, so we studied in 25 patients, and these patients are stabilized hemodynamically, and the life-threatening associated injuries were addressed, and the patients have been stabilized. If feasible, we used primarily the Elizoro external fixator, and if not, we used temporarily AO external fixator. And the Elizoro assembly application follows a standard protocol. And we devised a leg holder using the Italian arches and frames to form a leg holder, which we used. And the knee and ankle range of motion started the next day. So patients were followed up to 1 year, and the pin sites were carried, and any pin site infection was noted, and they were classified and managed according to Checkers and Outerbounds classification. And partial weight bearing was allowed once the wounds were settled, and full weight bearing depended on the presence or absence of associated injuries. So the fixators were removed based on clinical and radiological criteria. Clinical criteria was absence of pain at the fracture site, and the radiological criteria, as we know, the presence of bridging callus at least in 3 planes in the X-rays. And we had almost 48% of patients belong to the 4th decade, and 88% of patients were males. And there were 52% of type 3A injuries, a majority. And out of 25 patients, in the first 6 patients, we used Elizoro on day 1. So out of the next 19 patients, in 12 patients, Elizoro is applied in 3rd day, and remaining 7 patients 4th day. Therefore, in all the 25 patients, we applied Elizoro fixator within 5 days of following injury as a definitive method. And these are the complications. And about 10 patients had pin site infections, and these were managed by following the Checkers and Outerbounds principles. And this is the Checkers and Outerbound classification. They have graded the pin site infections into 6 grades. And this is our union of fracture. About 28% of fractures were united within 3 months, that is 12 weeks, and 48% of fractures united in 6 months, that is 24 weeks. And only in 5 patients there was a delayed union. So the fixators were removed at the end of 24 weeks in 12 patients, 32 weeks in 8 patients, and 48 weeks in 5 patients. And we had 2 patients with limb shortening, and these were managed non-operatively. And the maximum range of knee motion was obtained was 100 to 125 degrees, and maximum dorsiflexion achieved at the ankle was 35 degrees, and plantar flexion achieved was 20 degrees. One patient had ankle stiffness, which was with physical therapy got corrected. This is a Tucker's criteria which we use to assess the functional outcome. So an excellent outcome denotes a fracture union plus full knee extension with 125 degrees of knee flexion and 75% of ankle motion when compared to the normal side. If both sides are involved, ankle motion above neutral with 30 degrees flexion, no limb length discrepancy greater than 1 centimeter, angulation not greater than 7 degrees in any plane, rotation not greater than 15 degrees and no infection. This denotes excellent outcome. So when one criteria is missing, it denotes good outcome. When two criteria are missing, it denotes fair, and three are missing, it is poor. So this is the functional outcome analysis. And 14 patients, good to excellent outcome. Almost half of the patients, 53%, and remaining 11 patients, fair to poor outcomes. These are the case examples. So you can see the fracture is well united at the end of 5 months period. This is a functional outcome of a patient. So with the mainstay of management of open fractures is thorough debridement. Principles were laid by Dissolve and Larry, which are still relevant today.
Sum up fast.
So across many centers, open tibial fractures is thorough debridement, early antibiotics, hemodynamic stabilization, and primary internal fixation with intramedullary nail or temporary stabilization, followed by secondary internal fixation. But as we noted earlier, complications like deep infection, delayed union, need for bone grafting is high.
Time is over.
Silent.
Please conclude.
Yes. So the definitive treatment of open tibial fractures, especially type 3B fractures with irresolved ring fixator, is found to be optimal and cost effective. And it can be used as a primary definitive fixation in severe open tibial fractures, especially type 3A and 3B fractures. Thank you, sir.
Dr. F.R. Chaudhary from
Chairperson and all the delegates and faculty. I am Dr. Karthik MV and under the guidance of Harshad Shah sir. He is a surgeon. Today my topic is about the evaluation of tibial pylon fractures treated with Elizabeth external fixation. The term tibial pylon plafond was coined by Destot, a French radiologist, which means the plafond or the distal articulating surface of the tibia. The main complications of these fractures are challenging, which poses to the orthopedic surgeons is mainly because of these photographs which you are seeing on the slide, mainly because of the limited soft tissue coverage as well as the articular involvement. So if you open these fractures, it will invariably lead to the devastating complications. So tibial pylon fractures, it constitutes about 10% of other tibial fractures, and these are the variety fractures which you can see on the screen. So mechanism of injury, one is the axial loading, which is the fall from height, axial with rotational loading like road traffic accidents which lead to joint impaction, displacement of talus as well as articular combination. So we classified based on two classifications. One is Rudy-Algo, which mainly talks about the intra-articular extension, and second is the OTA classification, which talks about both extra-articular as well as the intra-articular extension. So subjects, total 2 years of duration of study, in which inclusion criteria, fractures of distal tibia which are treated by Elizabeth, and age group of 18 to 80 years, and exclusion criteria are the polytrauma patients, pathological fractures, and age less than 18 years. So based on the assessment is based on the clinical assessment by OIDR Bill score. It has two components. One is the subjective as well as objective. Subjective mainly the patient pain. Score 4 tells that the patient has no pain, and score 0 tells the 1 tells the patient has severe pain. And objective based on the range of movements of the ankle. And T-Nevis classification, mainly displacement of the malleoli on the radiograph. This is how we calculate the T-Nevis classification. And then sample size of about 27, most of them were males, most of them were road traffic accidents, others were fall from height and all, and 14 of them injured the left limb and 13 of them were right limb. So fracture classification based on Shernis or Gustilo-Anderson, 7 of them were open injuries classified on Gustilo-Anderson and closed by Shernis classification, 20 of them. Based on the OTA classification, 16 of them were under type C, most of them, and the Rudy-Algo classification talks mainly about the intra-articular extension. Type 2 was most common, and after this 2 patients were lost to follow. Preoperative plan, So the fracture mainly involves the distal tibia. So we have to stabilize the fracture by putting the two rings above the fracture site, ring 1 and ring 2. And if you are trying to span the knee, the ring 4 could be applied, or if you are not spanning, then ring 3 is enough if the fixation is stable enough. So this is the ankle spanning external fixator. There is no movement at the ankle joint. Next, this is the ankle non-spanning external fixator. There is good range of movements, dorsiflexion, plantar flexion, everything is possible. This is the first case where the preoperative shows distal and tibia fracture, for which the loss reduction external fixation was put. 6 months later, the elixir was removed. The patient has good ankle range of movements. So another case where it was treated with both internal as well as the external fixation. It was treated with the fibula plating and CC screw for medial malleolus as well as external elixir fixation. So post removal after 6 months, the fracture shows good union. This is the third case where the ankle was not spanned. We put 3 elixir interosseous wires, and ankle range of movement was preserved. So this is after the elixir removal. So the patient was able to do day-to-day activities and able to sit cross-legged without any problems. So this is the fourth case where it was treated only by elixir external fixation with spanning the ankle. Post removal of the fixator, it shows good union and no deformity. This is one of the case where the patient underwent surgery and got infected. Later the plate was removed and the elixir was put. So the infection got controlled after the application of removal. Elixir removal shows good union and no signs of infection and good amount of callus formation. So results, most of them achieved good clinical results after of which 13 of them based on the radiological scoring. Based on the clinical scoring, most of them achieved good clinical results. Additional 2 of them were requiring bone marrow infiltration, 2 required bone marrow and another 2 required both of them. So even though Lizardo application, most of them had a soft tissue complications, 7 of them were minus, 4 of them were major. However, none of them required any plastic surgery or references. 3 cases of them were non-union. There were no cases of arthrodesis, amputation and DVT. In our study, most of them achieved union within 7 months. Out of removing the 3 cases which underwent non-union, the average union time was 5.2 months. One of the limitation of my study is duration of follow-up.
Please sum up fast.
Duration of follow-up was severely late and comparative analysis could not be performed. And the conclusion of my study is Elizardo is a minimally invasive surgery which leads good result with less complication. However, these complications can be treated on OPD basis. Being the patient compliance is one of the most important for the treatment success. Thank you.
Thank you for finishing in time.
Postgraduate from Mother Medical College. Introduction. Periarticular fractures of the ankles in elderly patients are characterized by senile skin atrophy, poor dermal extensibility, and thin subcutaneous tissue. The use of bulky internal fixation material can cause the swelling that accompanies the fracture to induce secondary injury of the skin tissue. In pilon fractures, because of the soft tissue around the ankle joint is thin and there will be more complications. My aim is to evaluate the efficacy of elixir and fixator in elderly patients having pilon fractures. Methods: there are 37 patients of around more than 60 years of age, were classified Group A and Group B, where Group A is 15 patients treated with internal fixations like plate and nail. Group B are 22 patients with elixir external fixator. The study was Mela Medical College Hospital, the prospective study. The mobilization for internal fixation was started at around 2 weeks, with the full weight bearing mobilization started at 6 weeks. For elixir fixation, the partial weight bearing was started on the day, post-operative day on first itself. The full weight bearing mobilization was started on 4 weeks post-operatively. Follow-up, 2 years of follow-up period, once in a month for the first 3 months, and every 6 months following the surgery. This is the first case, 27 years old, came with the OPD, the RTA showing pilon fractures. We treated the immediate post-operative X-ray of the patient. This is the follow-up patient after 8 weeks. This is another case with both bone. We fixed the fibula with the flash knife and we fixed the fracture with the elixir. This is the overall outcome. The mean age of the patient for the internal fixation is around 74 and Elisa was 76. The duration of hospitalization stay was 79 and Elisa was 25 around. The range of movements in the sagittal plane is around 44 and the Elisa patient is 43. The bone mineral density we measured was 2.6 and the Elisa patient was 3.6. And the assessment was score was directed by JSSF. It shows around 79 point and Elisa was 80 around. There is no infected non-union was found to be in Elisa cases and skin disorders was around 0 at Elisa. And discussion, pillar fractures are difficult to treat because of interarticular extension. Even when it is perfectly reduced, the infection occurs due to soft tissue complications. With the close reduction, the probability of infection will decrease. There is no complications found to be in the Elisa group, fixator group. In addition to that, the T-score was significantly lower in the Elisa group rather than the internal fixator group. Even though the elderly patients in the osteoporotic and osteopenic bones, Elisa provides a better and rigid fixation with the multiple olive wires. And long-term non-weight bearing leads to a reduced walking ability in older patient. After the fixation of Elisa, there will be a significant changes in the weight bearing after the surgery. Conclusion, Elisa external fixator may be a useful option in the treatment of periarticular fracture of the ankle in elderly patient even it is a closed fracture. Thank you.
Thank you for finishing in time. Treat with bridging external fixator.
Good afternoon everyone. My topic of today's presentation is prospective study of functional outcome of distal radius intraarticular fracture treated with bridging external fixator. Lower radius fractures are very common and increasing incidence may be attributed to osteoporosis due to aging and growing higher range trauma. Bowlers use skeletal traction to maintain length during fracture healing. Anderson and O'Neill were the first to use external skeletal fixation. De Palma demonstrated value of soft tissues that remains intact following fracture of distal radius. Vidal et al. Coined the term ligamento-taxis. The fracture of distal radius are the type of injuries with different fracture patterns, which were first described by Porteous and Collis. This is the most common fracture treated by orthopedic surgeons. Incidence in males is 100 to 190 per 1 lakh populations, and in female is 282 to 458 per 1 lakh population in females. Multiple treatment modalities have been studied. The classic fracture originally described by Abraham Collis in 1814 and extraarticular distal radius fracture, which often does not with close reduction and immobilization in cast. In high energy injuries with severe combination and unstable intraarticular components, conservative treatment is more difficult. Recently, open reduction with fixation with plates as well as application of external fixation are considered to be the most popular fixation techniques in the treatment of these fractures. External fixation has advantage of a close reduction while anatomic radiocarpal alignment can be maintained sufficiently. Treatment by close reduction and immobilization cast can be carried out nationwide at the low cost without admission to hospital but gives of bone fragment and joint and no anatomical reconstruction. Good results are seen with the use of external fixator in comminuted intraarticular fractures. It maintains radial length best due to sustained ligamento-taxis. Kunis et al. Has revealed that 90% of patients had good to excellent results. According to McGill's system, 92% had no pain post-operatively and 89% didn't have deformity at the end of 5 years. Claiborne had reported that immediate post-operative full flexion and extension has lost some volatility on post-operative follow-up, and in patients where immediately post-operative only flexion was allowed and extension after 4 weeks did not lose volatility. External fixation is a common method of treatment of unstable distal radius fractures using ligamento-taxis across the wrist for approximately 6 to 8 weeks. The ligamento-taxis by external fixator. Ligamento-taxis result in sustained distraction of a fracture and facilitate anatomical reduction. Vamshi Krishna Chilakamri has concluded that ligamento-taxis is an effective method for treatment of complex intraarticular distal radius fractures. In our study, 30 patients with intraarticular distal radius fracture were treated with ligamento-taxis with external fixator. Materials and method. This is a Friedman classification we have used. The study design is a prospective cohort study using GMC Nanded. The study was approximately conducted for 1 year. Sample size is 30 and source is orthopedic and physiotherapy OPD. Assessment tool is modified Reno brain scoring system. Follow-up is immediate post-op 6 to 8 weeks. 6 months and 1 year. Post-operative complications are noted and reported. Inclusion criteria is skeletally mature patients, all displays intra-articularly comminuted fracture of distant radius including open fracture, injury less than 2 weeks old. Exclusion criteria is skeletally immature patients, pathological fractures other than osteoporosis and uncooperative patients. These are surgical procedures. Shanspin 3.5 mm used for radius and Shanspin 2.5 mm for metacarpal, and the connecting rods of 4 mm. Under suitable anesthesia, linear sustained traction was given. And this is a procedure. Post-operative complications. Immediate post-operative check was taken in AP and lateral views. Active exercises of all fingers and elbow and shoulder were carried out. The patient was discharged on second post-operative after the first dressing change. The patient was called for inspection and dressing change 1 week for next 6 weeks. The external fixator was removed on 6 to 8 weeks. Cases were followed up regularly at an interval of 6 weeks, 3 months and 6 months. The results. This is a modified Reno brain scoring we used. In this, excellent is 90 to 100 and good is 80 to 89. Fair is 65 to 79 and poor is less than 65. These are the descriptive analysis. These are the pre-operative X-ray and post-operative X-ray of the patient. And this is a functional outcome. You can see the range of motions. Discussion. This is a comparative study between R and other study. Kuniz et al. Has reported 85% of the patient with good radial height and improved volar angulation. Vidal et al. Has reported reduced with these fractures can be reduced with sustained ligamellotaxis. In our study, excellent results were obtained in 80% of the cases. Conclusion. The external fixator is inexpensive and simple modality. Intra-articular fractures when treated with ligamellotaxis has achieved the anatomical reduction. It outweighs open reduction and internal fixation with plating as it maintains the radial length best due to sustained ligamellotaxis. Careful review of recent literature reveals that external fixation appears to have benefit that outweigh associated complications and make it an attractive treatment modality for the fractures of distal radius that require surgical treatment.
Faster, please.
These are the pre-operative and post-operative X-rays with 3-week follow-up, 6 weeks and 3-month follow-up. This is a post-operative 6 months. We can see the whole range of motion.
Thank you for finishing your time.
I'm Postgraduate from Sivaraj Medical College Hospital. This is a case report of 23-year-old male presented to Sivaraj Medical College with complaints of deformity and shortening over right thigh and leg associated with difficulty in weight bearing for past 4 months. History of RTA 4 months back, following which he was diagnosed to have right shaft of femur fracture with right leg both bone fracture, for which he underwent native spending at the Puttur for 4 months. This was excess at the time of the trauma. This case comes under type 1 Blake and McBride classification of floating knee. Excess at 4 months post trauma. Patient presented us with right malinating shaft of femur fracture and right leg both bone malinating shaft fractures. Patient underwent right femur osteoclasis and open reduction and internal fixation with dual plating and right tibia osteoclasis. Open reduction and internal fixation with plating and bone grafting from right tibia crest and partial fibula. Patient developed active purulent discharge from right leg surgical site 9 months post surgery, for which wound debridement was done and IV antibiotics given, following which plaster of Paris was applied and advised non-weight bearing. Patient came back with complaints of pain and discharging sinus over right leg surgical site at 1 year post surgery, for which right tibia implant exit with sinus tract excision was done. Stability checked and POP was applied at allow non-weight bearing for 1 month, followed by synthetic cast conversion and full weight bearing for 3 months. And in April 2022, a patient presented with short limb gait for elective right lower limb lengthening procedure. Patient was assessed to have a total limb discrepancy of 5.5 centimeters, with 2 centimeter shortening noted over right femoral component and 3.5 centimeter shortening over tibia. Patient underwent right leg iliacal fixation with proximal tibial corticotomy with partial fibrectomy and percutaneous aggressed tendon lengthening. Patient had no angulation or translation or rotational deformity, hence direct limb lengthening was done using iliacal. This is a pre-optic patient's gait, short limb gait, and patient was having 15-degree equinus.
operative procedure, Elizar axonal fixator was pre-constructed with 3-ring frame. The proximal and distal rings are connected using rods and aligned in such a way that they were 2 centimeters away from the joint ring. The pre-construct was fixed to tibia with first ring at the level of head of fibula using Elizar OS in safe anatomical zones using standard Elizar principles. Partial fibrectomy was carried out at the junction of middle and distal fibula. Tibial corticotomy was done at the level of proximal metaphysis. Percutaneous Achilles tendon lengthening by tibial hemisection for Achilles tendon contracture was performed. Foot was brought to neutral position. Destruction was started on SAMD at the rate of 0.25 mm 4 times a day. Patient was started on ankle dorsiflexion exercise with the help of Theraban on 10th day. The rate of destruction was adjusted according to the quality of regeneration and was continued for 2 months until the desired length was achieved, followed by 4-month consolidation phase. Healing index in our case is 5x per centimeter. Fixate removal was planned at the end of 6 months, 3 weeks, and when the 3 bodices were visible radiographically after dynamization of the rings, the patient was able to eat well without pain and dynamized rings. The results of the procedure were assessed using a scoring system modified from ballet and the patient was found to have excellent outcome. This is the X-ray after consolidation phase. There is a 5.5 centimeter lengthening done tibia. X-rays post femur dual plate exit and Elizar removal 5 months post. These are post-operative images and our patient is having 10-degree dorsiflexion. All movements are normal. Our case comes under more than 90% excellent outcome. Problems are the difficulties that require no operative intervention to resolve, and the obstacles are the difficulties that require operative intervention. And complications are all intraoperative injuries and problems during limb lengthening that are not resolved by the end of the treatment. The most common problem we face during limb lengthening was that resolved without operative intervention was pin site infection, treated conservatively with regular dressing and antibiotics. Difficulties during limb lengthening were muscle contractures, joint relaxation, and accent deviation, neurological incident, vascular injury, premature consolidation, delayed consolidation, non-union and pin site problems, hard drive failure, pain, difficulty sleeping. Late complications are loss of length, late going, refraction and joint stiffness. Tibial lengthening with Elizar technique was safe and efficacious on our patient population. Despite the difficulties encountered during lengthening, our series presents an average lengthening at a lower complication rate, and thus a definitive improvement over the previous techniques. We find the technique safe, effective and believe it to be the method of choice for tibial lengthening. Thank you. We used to massage and give traction and apply with bamboo sticks with native oil.
But you have not told us, I think.
So,
did you tell us all about this?
Actually, this native printing was done in outside hospital.
Then properly, this topic is mentioned like that, as if you have treated the patient by native splitting. No, it was a complication of native splitting which you treated later by Elizar surgery, right? So choose your topic carefully. So.
Sir, in many type 5 and type 6 cases, actually apart from the first 2 cases, every cases you have shown as a separate posteromedial fragment in the proximal tibia. While doing Elizar, how to deal with the posteromedial fragment? Because that is
posteromedial fragments could be reduced by the safe zones using an olive wire, but posterolateral fragments we don't address due to neurovascular.
It's not only displaced, it is also depressed.
Yeah, depressed, we can use a mini open incision and you can elevate it and you can use a CC screw and you can wrap it through a CC screw and you can fix your frame.
So you will have to open posteromedial.
Yeah, mini open incision to avoid the structures and directly you can elevate it.
Okay.
My question to the last speaker. You have done lengthening in tibia or femur. So what is the shortening was? It's in tibia or femur?
And tibia 3.5 centimeter, 2 and 3.5, totally it was 5.5 centimeter.
So both tibia and femur have the shortening and you have done the lengthening in tibia only.
Yes.
So in this way, aren't you alternating the knee joint line, both the knees?
Yeah, but we did this CT scan, bone scan, where all the alignment and there was no translation or angulation.
But by this way, you are elevating the joint line, knee joint line, because you are doing the lengthening in the tibia only.
Yeah.
Sir, to the speaker, what this is?
Saskar. Is he there? Saskar, can you just... yeah. It's not question, I'm asking you cases, most of them, the type 2 and type 3, I think, the final ones, the 5 and 6, they have got a soft tissue injury. And sometimes a lot of blades in this and that way. So what is the time you put your system? What time? Like patient has developed this and it has come to you when you are going to develop.
Use a skeletal skin traction, or the next day, depending upon the local condition or the compartment, or we might go in different cases. We might go with an external fixator initially on the day one on the presentation, and then we go to have an laser fixator.
Like a patient has come 3 days old and lot of blades and other things. Are you going to take him immediately or you wait for some more time? If yes or if no? Yes.
Sir, with a lot of clips and all, it depends upon how much scope.
There is a red blips. Red blips.
Yes, sir.
Yeah. When you are going to take up?
Sir, till it reduces and
No. Immediately. It should be done immediately.
Yes, sir.
Because if you do it immediately, we have seen from our experience that by 6-7 days everything settles. Thank you very much. Yeah, the intra-articular pylon, which is more difficult rather, and which has got a lot of implication on the final outcome. So how do you ensure on the table that your chaput, the movements and the medullary fractures components are being reduced accurately?
So, the
X-ray?
no, sir,
CR. Okay. Then how do you diagnose that these fragments are there, what is their size and combinations and other things? Because they are the final result you will get. In any of you, I have not seen any CT scan cut within just within 1 centimeter of the knee, ankle joint to see all these fragments horizontally. And that should have been done. I was expecting that. Which part, how much centimeter, how much millimeter from lateral malleolus, something like that. So planning, you need to have an intra-articular shot of axillary cut in the horizontal cut in the CT scan. You can nicely plan it and put it. And number one. Number two, do you regularly use foot ankle stabilizer? Foot stabilizer in all the intra-articular fractures in Elizabeth?
So we will try to not span the ankles. We'll put a cross wires at the distal fragment if the construct is...
How many cross wires you usually put?
Minimum of 2, but 3 would be good, sir.
It should not be 2 minimum, it should be 3. Because you have to fix all the 3 components. And this is very important. What is the first step of putting all these wires in pylon fracture? You have got a medial malleolar component, you have got a caput and the movements and as well as the fibular fracture. So which component you are going to put your wire first?
The medium malleolar component.
Anybody? Why?
So once we put
Wait, he's telling lateral. Okay. How do you put it? How will you put it?
Not sure, sir.
You are not sure. You should ideally fix the lateral malleolus with an intra-medullary olive wire from below upwards, number one. This will take care of your anterior, inferior, tibio-talar ligament as well as in the posterior side. Once you reduce the fibula, these ligaments will act as a ligamento-taxis and put all these two fragments into place. Anterior, inferior, tenotibial and the posterior part also. Then accordingly you put your olive wires and fix it nicely and you get everything. And most of the time you have to do a CR after putting the fixator and do the moments. If they show some amount of instability, then you'll have to fix the subtalar joint or the foot part, otherwise you do not have to put it. Thank you.
To decide whether to span the joint proximal or distal, any criteria. It should not be a rule or it should not be a personal choice. There must be some scientific basis or some logic. बोलिए सबसे पहले शॉर्टकट पर्सन, when to span the knee, when not to span the knee. Any criteria? No. Personal choice. Okay, violent people. I have not seen counter opposed olive in any of your cases. Why? Why? You have not put counter opposed olive. You don't want to fix the different fragments. If you put two counter opposed olives, you would not need to span the ankle joint. That would help. Right? Any more questions?